Uh, Good
Okay.
evening, all. We start with today's presentation. Today's topic is syphilis in pregnancy. This is UK National Guideline on the management of syphilis, published in year 2015. This guideline is going to be very, very important from examination point of view. Both SBAs and EMQs can be asked on this topic. There are two things which we are going to cover. One is a UK National Guideline on the management of syphilis, and another TOG article, that is syphilis in pregnancy. So two things which we are going to discuss. One is a UK National Guideline on the management of syphilis published in 2015. Another is a TOG article, syphilis in pregnancy, identifying and managing a historic problem on the rise. Okay. Now coming to the epidemiology. Syphilis is relatively not very common, but it is generally associated with HIV-1 co-infection. Almost 40% of patients with syphilis may have HIV-1 as a co-infection. Okay. What is the importance in the pregnancy? It is the leading infective cause of stillbirth in countries where syphilis is endemic. Okay, maternal fetal transmission can occur during the pregnancy. Adverse fetal outcomes during pregnancy, what we get is a low birth weight, stillbirth, and congenital syphilis. Now coming to the screening and treatment. Among women which are screened positive during the pregnancy, only 40% will require antibiotic treatment. Why only 40% will require antibiotic treatment, doctor? Anyone? What about others?
No idea.
Yeah, see, either it can be a false positive test, or the lady can be already treated, because the test may remain positive even if she is adequately treated. Okay, so only 40% patients will require treatment when their screening test is positive. The risk factors which are associated are low socioeconomic status, multiparity, previous STI, illicit drug use before 18 years of age, illicit drug use by the current partner, poor engagement with antenatal care, and more than three or equal to three partners in the previous 12 months. Please remember these risk factors, because your scenario may have such kind of risk factors. Okay. Now let's come to the transmission of the syphilis. What are the modes of transmission? The sexual contact is the most common route. Approximately one third those who are exposed will get infected. Okay. And what are the extragenital sources or the routes of entry? It can happen via anal route, rectal route, oral mucosa, etc. Okay. Now, vertical transmission, that is the through placental transmission, can happen. It can occur at any stage of pregnancy. Okay. The risk of fetal transmission will depend upon the stage of maternal infection and the duration of fetal exposure. Okay. Now, what are the stages of syphilis? Traditionally, we know that it has got a primary, secondary, and tertiary stages. And there is another stage called as latent syphilis. So let us put it into the proper phases. So early syphilis, what does it include? It includes primary syphilis and the secondary syphilis. It is characterized by the active clinical symptoms. Second is a latent syphilis. Latent syphilis is an asymptomatic phase where there are no clinical signs or symptoms. The patient is serologically positive, but still can transmit the infection. So it is a stage where the patient is asymptomatic, serology is positive, and the patient is infectious. That is what is the latent stage. Okay. Now this latent stage is also divided into two. It is early latent
Okay.
or the late latent syphilis. Okay. Early latent, when the infection is acquired within previous 1 year, and late latent when the infection is acquired more than 1 year previously. Now here
Sir,
I have
let me
highlighted this
inform
1 year
you.
because there is little discrepancy in both the sources.
Yes.
In the beginning, I have mentioned that we are going to discuss one TOG article and the UK National Guideline. Now, this is the TOG article. What does this TOG article says? Early latent syphilis describes infections that occurred within past 1 year, whereas late latent syphilis describes infection that occurred more than 1 year ago. So this is what I have just mentioned. Now let us come to the UK National Guideline. What does it say? Secondary syphilis will resolve spontaneously in 3 to 12 weeks, and the disease enters in an asymptomatic latent stage. This is defined early within 2 years and late after thereafter. Okay, so ending with development of the tertiary stage. So according to the national guideline, the early latent is within 2 years and the late latent is after 2 years. While as per the talk, early latent is within 1 year and late latent is more than 1 year after the infection. Okay, so there is a little discrepancy. I just wanted to highlight, but don't get confused. Okay, both options will not be given. Okay, now coming to the latent syphilis, which we have just discussed, that secondary syphilis will resolve spontaneously in 3 to 12 weeks. Disease will then become asymptomatic latent phase, and patient has got no clinical symptoms, but still the serology is positive. Okay, so early latent is within 2 years, late latent is infection more than 2 years as per the UK National Guideline. Now, what is the clinical importance? Distinction is arbitrary but clinically relevant. 25% of patients may develop recurrence of secondary syphilis during the early latent phase. So you have got a primary syphilis, you have got a secondary syphilis. After the secondary syphilis, generally there is a resolution within 3 to 12 weeks and the patient will develop and go into the latent syphilis. But out of these latent syphilis, 1 in 4 patients, that is 25% patient, will develop recurrence of the secondary syphilis during the early latent phase. Okay. Now coming to the tertiary syphilis or the late syphilis. It develops later 20 years after the initial infection, rarely encountered in obstetric population, and major complications will be neurological, that is neurosyphilis, then gametous lesions and cardiovascular disease. Okay. Now coming to the primary syphilis. Incubation period is 3 weeks after the exposure. The range is 9 to 90 days. Primary lesion is described as a chancre. It begins as a single papule at the site of infection. It progresses to chancre. Okay, it is a painless, indurated, and non-purulent. Okay, so they may give you the image also and the scenario. So painless, indurated, non-purulent ulcer. Other features such as if extragenital, the lesion may be multiple and painful. So remember, in extragenital cases, the syphilitic primary ulcer may be multiple, but genital ulcer generally painless, indurated, single. Okay, spontaneous healing occurs within 3 to 8 weeks. Progression, if untreated, 1 in 4, that is 25%, will develop secondary syphilis. Now coming to the secondary syphilis, it occurs 4 to 10 weeks after the appearance of the primary chancre. So systemic infection manifestations will be flu-like symptoms, malaise, loss of appetite, generalized lymphadenopathy. So this kind of mucocutaneous lesion or the mucocutaneous rash will be there in cases of secondary syphilis. Generally, this is seen on the palm of the hand. Okay. So mucocutaneous features, there will be generalized rash. It involves the mucous membrane, characteristically affects the palms and soles. Then condyloma lata. They are perianal, discolored, warty lesions, highly infections, may also occur extragenitally. Okay. Other organ involvement like meningitis, ocular disease such as uveitis, optic neuropathy, hepatitis, glomerulonephritis, splenomegaly, etc. Then usually this will resolve within 1 to 3 months and the disease will then enter into the latent phase. And 1 in 4 patients may develop recurrence during the early latent stage, as we have already discussed. So in the secondary syphilis, just remember these mucocutaneous lesions and the condyloma lata. Two things, rash, that is mucocutaneous rash, and the condyloma lata, along with other systemic features. Okay, so these are the, but these two you have to remember because these are the key features along with other symptoms. Okay, that is hepatosplenomegaly, then glomerulonephritis, lymphadenopathy general. So these will be associated. Okay. Now coming to the late syphilis or the tertiary syphilis, it develops in 30% of untreated patients. It will appear 20 to 40 years after the initial infection. Now, this late disease will also have 3 types of manifestation. Okay, so it may be gametous disease, it may be cardiovascular syphilis, or it may be late neurological complication, that is late disease. Okay, so with neurological complication. So gametous disease is the most common, seen in 15% of patients. Cardiovascular is seen around 10% of patients, while neurological complications are least, that is 7%. Okay, so in the tertiary syphilis also, third tertiary stage or the late syphilis, we have 3 different manifestations. One is gametous, that is the most common, then cardiovascular, and then late syphilis neurological complication, that is seen in 7% of cases. Okay, so this is about the late disease, and even in the late, the patient can be asymptomatic also. Okay, so gametous syphilis, the pathology is there, granulomatous lesion with central necrosis. Okay, it may occur within 2 years of the latency, but more commonly occurs 15 years after the infection. So the latency for the gametous disease is 2 to 15 years. Okay, common sites are the skin, bones can occur anywhere in the body, but it responds rapidly to the antibiotic therapy. Okay. Now coming to the cardiovascular syphilis, it usually occurs 15 to 30 years after the initial infection, becomes symptomatic or complicated in 10% of patients. Common site is the ascending aorta, that is the most frequently affected, and major manifestations are the aortic dilatation, aortic wall regurgitation, other possible complications like coronary artery involvement, saccular aneurysm formation, etc. Here is an SBA, which part of the aorta is affected in the syphilis. So it is the ascending aorta. This was the question which was asked in January 2022. Okay, so please remember, here is a SBA. There are many SBAs in here. Okay, now coming to the neurosyphilis, that is the neurological complication may occur years after the infection, and it will include meningovascular complication. Now this neurological will also will have a three different types. Okay, meningovascular syphilis, general paralysis of insane, that is GPI, and third is the Tabes dorsalis. So late syphilis we have seen already three different manifestations, that is gummatous, cardiovascular, and neurological. And in the neurological also three different presentations. It may be meningovascular syphilis, second is a GPI, that is general paralysis of insane, and third is a Tabes dorsalis. Okay. So meningovascular syphilis, 5 to 10 years after the infection, it may occur earlier also. And pathology is the infectious arteritis affecting the cerebral vessel. So what is the pathology? It is the arteritis. Okay. So infectious arteritis affecting the cerebral vessels, and it may lead to the ischemic stroke. Middle cerebral artery is the most commonly affected. So this can be an SBA. Okay. Prodromal symptoms may be there week to months before the stroke. There can be headache, emotional lability, and insomnia. Okay. So next type of presentation is general paralysis of insane. Okay, it occurs 10 to 25 years after the infection. There is a progressive cortical neuronal loss, and the presentation will be forgetfulness, personality change, severe dementia, seizures, hemiparesis. Oh, ultimately the patient will develop dementia, but before that the initial milder symptoms such as forgetfulness and personality change will be there. Okay. Third is the Tabes dorsalis. Okay, it happens the late 15 to 20 years after the infection. It has got the longest latency among the neurological complications. So among the neurological, the longest latency is seen in the Tabes dorsalis. Okay, so pathology is the degeneration of the dorsal column. Okay, we know the dorsal column is responsible for the joint position position sense. Okay, so there is a loss of joint position sense here. Okay, there is a stereognosis and a barognosis loss is there. Okay, so presentation is a sensory ataxia, lightning pains, there is Urgil Robertson pupil, loss of reflexes, loss of vibration sense, and loss of joint position sense. So these are lost because they are these sensations are carried via the dorsal column. Okay, please remember these clinical manifestations. Okay, and this Urgil Robertson pupil, in which accommodation reflex is present, but the light reflex is absent. Okay, so ARP, accommodation reflex present, but the light reflex is absent. So, and it has got the longest latency in the neurological complications. So they can ask any of the SBA here, maybe about the latency. In the neurosyphilis, I mentioned that patient can be asymptomatic also. Okay, then meningovascular syphilis, 2 to 7 years of latency. Then general paralysis of insane, around 10 to 20 years. Tabes dorsalis, that is the longest latency, 15 to 25 years. Cardiovascular latency is around 10 to 30 years, and gummatous can be 1 to 46 years. Okay. So these are the things which you should remember here. Okay. Now in neurological syphilis, the CSF criteria supporting a diagnosis of neurosyphilis. These CSF criteria are different for HIV negative individual and the HIV positive individual. Okay, so there will be leukocytes more than 5 microliter per microliter, then protein more than 0.45 gram per liter. VDR and RPR on the CSF will be positive. TPPA will be positive, more positive in 1:320 or more. Okay, so protein same, more than 0.45 gram per liter in both cases. RPR and VDR will be positive, and TPPA will be positive more than 1:320. While WPCs in HIV negative individual will be more than 5, but HIV positive will be more than 20. Where if the HIV positive individual is on having a good immunity or is under good control, that is CD4 count is less than 20 or viral load is undetectable. In that particular case, the value of the WBC may be 6 to 20 also. Okay, so what we have seen up till now is a primary syphilis, secondary syphilis, tertiary syphilis. Okay, in between there is a latent syphilis, and a latent can be early latent or the late latent, and the tertiary syphilis or the tertiary stage can have gametous manifestation, cardiovascular manifestation, neurological manifestation. Neurological can be also of three types. Okay, meningovascular syphilis. Then you can have GPI, that is general paresis of Insane, and third is a Tabes dorsalis. Okay. Now coming to the congenital syphilis, and most of the time in the examination, congenital syphilis they are asking. Okay. Now coming to the determinants of the clinical presentation for congenital syphilis, it will depend upon the duration of the maternal infection and the timing of the maternal treatment during the pregnancy. One thing you remember, if the mother is treated for more than 30 days before the pregnancy, in that case, the chances of congenital syphilis are tremendously reduced. Okay, so if she receives the complete treatment before 30 days of the pregnancy, the chances of congenital infection will be tremendously reduced. Okay, now coming to the clinical presentation at birth, two-thirds patients or the infants are asymptomatic at birth. Remember, how many will be symptomatic? Only one-third will be symptomatic. Okay, most will develop symptom within 3 to 8 weeks, and majority present before 12 weeks. So these can be asked as a SBA. Only one-third are symptomatic, two-thirds are asymptomatic. Most will develop in 3 to 8 weeks symptoms, and majority will develop before 12 weeks. Okay. Now this congenital syphilis is also of two types. Okay. Early congenital syphilis and the late congenital syphilis. Okay. Now early congenital syphilis, the common manifestations, almost 40 to 60% will have at least one manifestations. Okay. Remember these manifestations, there will be skin rash, hemorrhagic rhinitis, also called as bloody snuffles, lymphadenopathy, hepatosplenomegaly, and skeletal abnormalities. Okay, so cutaneous rash along with lymphadenopathy, hepatosplenomegaly, and hemorrhagic rhinitis, okay, or the bloody snuffles, these and the skeletal abnormalities. These are the manifestations in the congenital syphilis, which happens within 2 years. Okay, other possible features in early syphilis could be congenital syphilis could be condyli malata, vesiculobullous lesions, osteochondritis, periostitis, pseudoparalysis of Parrot, then mucus patches, perioral fissures, non-human hydrops, glomerulonephritis, ocular involvement, etc. Now, late congenital syphilis, that is more than 2 years. Now, what happens here in late congenital syphilis? These manifestations, there is a persistent, chronic persistent inflammation. So, this osteochondritis, periostitis will lead to the fixed bony malformations. Okay. In one thing which you should remember in late congenital syphilis is the Hutchinson's triad. It is characterized by the Hutchinson's triad, that is eighth nerve deafness, interstitial keratitis, and Hutchinson's teeth. Okay, that is notch incisors. Okay, this is the Hutchinson's triad which is seen in late congenital syphilis: eighth nerve deafness, interstitial keratitis, and Hutchinson's teeth. Okay. Now coming to the skeletal and craniofacial features, as I mentioned, it is because of chronic persistent inflammation. There will be mulberry molars, high arch palate, frontal bossing, short maxilla, mandibular protrusion, raggeds, that is perioral features, saddle nose deformity due to syphilitic rhinitis, Saber shins, sternoclavicular thickening, Clutton's joint, etc. So, if you have given a feature, they may give you that the mother is delivered, mother was having the syphilis, and the child presents after 2 years, and they may give you various presentation. So please see to it that whether these manifestations are because of the chronic persistent inflammation. So do not get confused between the early and the late. Okay, so in early, skin rash, hemorrhagic rhinitis, lymphadenopathy, hepatosplenomegaly, and mainly in form of skeletal abnormalities, osteochondritis, periostitis. While here there will be malformations such as high arch palate, frontal bossing, short maxilla. This is because of the persistent inflammation. Okay. So we go ahead, and other complications can be paroxysmal cold hemoglobinuria, neurological involvement such as intellectual disability, cranial palsies, etc. Then prognosis around 1/3 to 1/4 children more than 2 years may be having asymptomatic neurosyphilis. Infants with congenital syphilis have 10% higher risk of death in the first year of life. So 10% of the congenital syphilis babies may not reach the first birthday of their life. Okay. Early detection and appropriate treatment significantly reduce the neonatal complications. Hutchinson's triad in the congenital syphilis is the late congenital syphilis, you remember, interstitial keratitis, eighth nerve deafness, and the Hutchinson's tip. Okay. Now coming to the diagnosis of congenital syphilis. Okay. It is the direct demonstration of the organism by dark field microscopy or the PCR testing. What will be the sample? You can take the exudate of the suspicious lesion or body fluid such as nasal discharge and demonstrate the treponema pallidum. Okay. Second, you go for a serological testing. Okay. You will perform the blood test on the fetal blood, not on the cord blood. Okay. And if the test is positive on the infant's blood, then you will also do the parallel maternal testing. Okay. So if infant screening test is positive, perform test parallel for infant and mother. And what are the tests which you will do? You can do treponemal IgM EIA, quantitative RPR or VDRL, or quantitative TPPA. So these are the tests which are recommended for diagnosis of congenital syphilis, serological testing. Okay. Here, please remember this particular chart, they have not asked up till now, but here they can ask you EMQs. And the chart, if you understand well, there should not be any difficulty if any EMQ comes on this. Okay. Now this congenital syphilis criteria to be applied for diagnosing the congenital syphilis. Now these criteria are absolute, major, minor, and the serology. Okay. Now if you have got a demonstration of the treponema pallidum either by dark ground DGI or PCR or histology, it is an absolute criteria for the congenital syphilis. So if you can demonstrate treponema pallidum, that is the absolute. Okay. Then you have got a major criteria which are condyloma lata, osteochondritis, periostitis, and the snuffles. Okay. Then minor, that is fissures of the lips, skin rash, mucus patches, hepatomegaly, splenomegaly, generalized lymphadenopathy, neurological signs, hemolytic anemia, CSF pleocytosis, etc. So major criteria are the condyloma lata and bone. Okay, so skin lesions and the bone lesions and hemorrhagic rhinitis. These are the major. So remember, skin, bone, and hemorrhagic rhinitis are the snuffles. These are major. Now, skin lesion will be in form of condyloma lata and bone lesions will be osteochondritis, periostitis. Okay, so major you will remember 4. That is condyloma lata, osteochondritis, periostitis, and snuffles. Then coming to the minor, rest all will be minor. Okay, that is the skin rash, mucus patches, hepatosplenomegaly, lymphadenopathy, etc., etc. So those will be the minor. Now please concentrate on the serology. Okay, serology, the test either VDRL or RPR we are going to do, or TPP or TPHA. Now this serology is divided into 5 types: A, B, C, D, and E. This you need to understand well. Okay, A, B, C, D, and E. What is A? A is your screening test is positive. VDRL or RPR or TPP or TPHA is positive. Okay, so your test is positive. Second, your IgM antibody is positive. That is B. C type is your test is negative. RPR or VDRL, TPP or TPH is negative. That is C. Okay, then serology D type is positive VDRL or RPR, which is not becoming negative within 4 months. That means persistent VDRL or RPR is positive for 4 months. Okay. Next, serology type E is rising RPR or VDRL titer over a period of 3 months. That means your titers are rising. Okay. So serology is of 5 types. 1, only positive. B, positive IgM. C, negative VDRL and RPR or other test. D, positive, not becoming negative within 4 months. And E is uh, rising titers over a period of 3 months. So these are the 5 different types. And accordingly, then you concentrate on this table, certainty of congenital syphilis diagnosis from assessment of the infant using these criteria. Now your infection may be definite probable, possible, and unlikely. Now, what is definite? If you can demonstrate the treponemal pallidum, definite. So one or more absolute criteria, there is only one criteria, that is demonstration. Okay. So treponemal pallidum demonstration either by DGI or PCR or histology, it is a definite. Okay. So it can be definite, it can be probable, it can be possible, or it can be unlikely. Okay. Now, definite you have understood. Now directly go for unlikely. Unlikely is serology C. That is your test is negative. VDRL or RPR is negative. TPP or TPH is negative. Okay. Then serology A or B, but mother is adequately treated, is your unlikely infection. Okay. So that means your test is positive, VDRL or RPR, or you are getting IgM which is positive, but there is a history that the mother is adequately treated. In this case, it is unlikely to be congenital syphilis. So definite and unlikely you should be very sure, because you have either A or B here, but the mother is adequately treated, or serology is C type. Is this clear to you? Is it clear?
Yes, sir.
Okay. Now go for probable or possible. Okay. Now probable is serology is D or E. Okay, serology is D or E. That means the positive RPR or VDRL which is not becoming negative. Okay, E is rising titers. So you have a serology E or D, that is probable. Then other one major criteria plus serology A or B. Okay, so you have one major along with only test is positive, either IgM positive or the screening test positive, along with one major criteria, or two major criteria with A or B. Okay, or one major and one minor criteria, that is probable. So you have one criteria from here, one criteria from here, that is also probable. Okay, now so this D and E is most important in probable. If you go for major, then one major along with AB, or two or more minor along with A or B, or one major and one minor will be probable. And what is possible? Serology A or B with no clinical criteria. You just have serology positive, but there is no clinical manifestation, that is possible. Okay, so it's a little complicated, but if you understand it, it's very easy. Okay, so it's only 5 types of serology if you understand: test positive, IgM positive, test negative, then positive not becoming negative within 4 months, and rising titers. If you have understood, then you just put it along with the clinical criteria, and your infection may be definite, probable, possible, and unlikely. Okay, we'll go ahead. Now, what are the 10 important points which you should remember? One is the transplacental transmission of the treponemal pallidum can occur at any stage of pregnancy. Risk of infection depends on the stage of maternal disease and duration of fetal exposure. Two-thirds of affected infants are asymptomatic at birth, but most develop symptoms within 3 to 8 weeks. Early congenital syphilis presents before 2 years of age, commonly with rash, hepatosplenomegaly, lymphadenopathy, and bloody snuffles. So snuffles, that is hemorrhagic rhinitis, is a classic early sign and is highly infectious. Skeletal involvement in early disease includes osteochondritis, periostitis, pseudoparalysis, that is Parrot pseudoparalysis. Late congenital infection more than 2 years results from chronic inflammatory damage similar to tertiary syphilis. Hutchinson's triad is pathognomonic of late congenital syphilis, that is interstitial keratitis, 8 nerve deafness, and Hutchinson's 2. Early congenital syphilis, snuffles and systemic disease. Okay, snuffles and systemic disease, early congenital disease, syphilis, and late congenital syphilis, Hutchinson's triad, and skeletal deformities. Okay. Other classic stigmata will include saddle nose, Saber-Shins, mulberry molars, frontal bossing, Clutton joints. This is in the late syphilis you see. Okay, treponemal IgM in the infant indicates true infection because IgM does not cross the placenta, while IgG may be maternally transmitted. Okay, so these are the 10 points which you should remember about the congenital syphilis. Okay. Now, one more thing. One question has been asked as an SBA. How early the syphilis can get transmitted transplacentally? Okay. Now, for this, again, there are two different answers which I found in the both guidelines. Okay. First thing you remember, syphilis can have transmission at any stage of pregnancy. That is what is mentioned in the guideline. Second, what the guideline mentions here, from as early as 14 weeks of gestation, spirochete bacteria can cross the placenta and cause fetal infection. So another answer could be 14 weeks of gestation. Okay. The risk increases as the pregnancy progresses toward the term. Fetal loss is common with 30 to 40% chance of stillbirth. Okay. Fetal loss is often caused by the infection of the placenta or compromised blood flow to the fetus, and the fetus may survive. Around one third will be born with signs of congenital syphilis. So 30 to 40% chance of stillbirth can be SBA. How early it can get transmitted? As early as 14 weeks of gestation, it can get transmitted. This is what it. And if you read this talk article, in the talk article they mention, although fetal infection usually occurs late in pregnancy, it has been demonstrated as early as 8 to 9 weeks of gestation. So it may be answer maybe 8 to 9 weeks also. Okay. So that is what I just wanted to highlight. One is at 14 weeks they have given, at another they have given 8 to 9 weeks of gestation. Okay. Now, what are the fetal ultrasound features of congenital syphilis? What is the pathophysiology? Fetal infection usually causes placental involvement and fetal hepatic dysfunction. These are the two important things which you should remember: placental involvement and fetal hepatic dysfunction. Okay, it leads to the IUGR, fetal growth restriction, anemia, thrombocytopenia, and ascites. So this is what is the pathophysiology you get, and associated adverse outcome will be preterm birth, stillbirth, neonatal death. Important point is that ultrasound findings are non-specific but suggest intrauterine infection. Okay. So common ultrasound features are ascites, hepatosplenomegaly, intrahepatic calcifications, and placentomegaly. So ascites, that is the fluid accumulation in the fetal abdomen; hepatosplenomegaly, enlarged fetal liver and spleen due to infection; intrahepatic calcification reflect inflammatory damage in liver; and placentomegaly, enlarged placenta due to infection. Severe ultrasound findings such as fetal hydrops and distorted fetal long bones. Then fetal hydrops is seen in around 6 to 10% of congenital infection. Mechanism is disseminated endothelial and capillary damage will cause fluid shift into the fetal compartment. Okay. So triad suggesting fetal syphilis on ultrasound: hepatosplenomegaly, placentomegaly, and ascites. Okay. So non-immune hydrops along with hepatosplenomegaly and placentomegaly, you think of this fetal hydrops, congenital syphilis. Okay, so fetal hydrops, you see here the ascites and the pericardial or pleural effusion. Okay, so the image depicts ascites below the diaphragm and large pleural effusion above the diaphragm. Okay, so this is what is seen. Then here you see the intrahepatic calcifications. Okay, now coming to the lab diagnosis. Okay, the test, dark field microscopy. Advantage with this is that it gives rapid results. It will detect the treponema pallidum before serological response develops. Okay. Limitation is that it requires experienced observer, less reliable in rectal and non-penile genital lesions, and not suitable for oral lesions. Okay. Because oral sometimes you can have commensals. Okay. Then PCR. PCR is useful for oral lesions where commensal also exist. Okay, it can detect treponema pallidum DNA in tissue samples. It can be used for vitreous fluid and CSF also. A limitation is that usually available only in reference laboratory. So PCR limitation is it is available only in reference laboratory. Now coming to the serological test. For serological, important limitation is treponemal antibody test cannot differentiate syphilis from endemic trypanosomosis, that is yaws, Bgl, pinta. These are other trypanomal infections from which you will not be able to differentiate this syphilis. Okay. There are two types of serological test. One is a non-trypanomal test, that is VDRL and RPR. It will detect cardiolipin or reagent antibodies. Second is a trypanomal or specific trypanoma specific test such as EIA, CLIA, TPHA, TPPA, FTABS, and treponema immunoblot. Okay, it detects antibodies specific to treponema pallidum. So you have two types of serological tests. One are non-specific and second are specific. Non-specific one are the VDRL and RPR, and specific are the EIA, CLIA, TPHA, TPPA, etc. Please do not select this FTAB as an answer anywhere. We'll see that in subsequent slides. Okay, so non-treponemal test, that is VDRL RPR, is used for screening and monitoring treatment response. Treponemal test is used for confirmation of the diagnosis. Okay, so non-treponemal test, that is VDL and RPR, they are used for screening and monitoring. Remember that the role of non-treponemal test is screening and monitoring, while treponemal tests are used for confirmation of the diagnosis. Treponemal tests usually remain positive for life even after treatment. So these treponemal tests will remain positive after the treatment also. Now, see, the if the lady is screened at booking, the tripanal serology to detect both IgG and IgM. The tests which are done are EIA, CLI, TPPA, or TPHA. Okay, so these are the tests you can do. So screening EIA, CLI, TPHA, or TPPA. Okay, so these are the tests. So possibilities that it can be positive or it can be negative. Negative, okay, no problem. But if it is a positive, then you have to confirm. Okay, then confirmatory testing is required. How will you confirm? First thing, now the test which is used is either CIA or CLI. Okay, if this test is used, then send the original sample to the different treponemal test, that is TPPA or TPHA. Okay, so we have seen 4 different tests which can be used, CIA or CLI. So if the test is done with CIA or CLI, EIA or CLI, then we have to use the same sample but different test, that is TPPA or TPHA, and we have to take new sample and test with the same test which was done before, that is EIA and CLI. So once the test is positive, we have to reconfirm with another test and another sample. Same sample, different test, different sample, same test. Okay, so if you have done EIA or CLI, you will take another sample and do the same test. Okay, and on the same sample, you will do the different test. Okay, is it clear to you? Because they can ask you next step. Is it clear?
Yes, sir.
Okay,
Yes,
so
sir.
then you confirm that the sample is positive. Okay, once the sample is positive, then you carry out RP or VDRL, because we want to monitor the titers, because we will start the treatment and we'll monitor the titer. Okay, so positive perform quantitative RP or VDRL test to elicit antibody titers to use for monitoring. Okay, before starting the treatment. Okay, that is what is they recommend. And simultaneously, we have to refer to GUM, pediatric or neonatal care, to commence a complete BASH congenital syphilis birth plan. So simultaneously, you have to do the referral to the GUM so that we can have a birth plan for that particular need. So antenatally, when we screen, we have to remember this flowchart very well. And please, you will understand what you will do. But along with that, don't forget that you have to do the VDR and RPR. Along with, you have to do the referral to the GUM clinic. Okay, because we have to formulate the syphilitic plan. Now, what about the negative? If the test is negative, but this lady is from a high risk category, then offer repeat screening 3 monthly. Consider this if woman is declined at booking, or if any of the following risk factors are present. Okay, new or multiple sexual partners, commercial sex workers, sexual contact with MSM. In this particular case, you will repeat the screening test after 3 months. They may give you in the scenario that lady has declined the testing, then you will offer that, your answer will be you will offer the test after 3 months. Okay, or even if the test is negative but she is fitting into the high risk category, such as this new or multiple sexual partners, commercial sex worker, etc., you will offer the repeat testing. Okay, now coming to the treponemal antibody test, what is the principle which is used? These tests are based on recombinant treponema paradigm antigens. They detect treponemal specific antibodies IgG and IgM. Okay, treponema paradigm specific IgM antibody test examples are treponema anti-treponemal IgM EIA, treponemal IgM immunoblot. Clinical role, it may be helpful when primary syphilis is suspected. Limitation is that suboptimal sensitivity should not be used to stage the disease and should not determine duration of the treatment. Now, primary screening test. This is the same thing what we have discussed in the chart. Okay, the same thing here it is written. The test will be EI or CLI. That is enzyme immunoassay or chemiluminescent immunoassay, preferably detecting both IgG and IgM. That is the test of choice. Alternatively, you can use TPPA or TPHA. TPPA, that is treponema pallidum particle agglutination assay. This is TPPA is preferred over TPHA. So if you have these two options, then prefer TPHA because TPPA is preferred over the TPHA. Okay. Now the confirmatory test. Okay. If the test is positive, confirm with a different treponemal test. Supplementary confirmation test is IgG immunoblot, recommended when standard confirmatory test does not confirm positive screening result. So if this standard test, EIA, CIA, CLIA or TPP or TPHA, if these tests do not confirm, then you use supplementary confirmatory test as IgG immunoblot. Okay. Test which is not recommended routinely is FTA ABS, not recommended as a standard confirmatory test. Confirmation of the positive results, a second specimen should always be tested to confirm the positive results, and specimens should also be taken on the day of treatment commenced to document the baseline VDRL and RPR. So the same thing what we have discussed in the flowchart is given here. Okay. Now coming to the test for assessing the serological activity. How will you assess? By RPR or the VDRL? You will do the quantitative non-treponemal test, that is RPR, the rapid plasma reagent test, or venereal disease research laboratory test, that is VDRL. Purpose, it helps to stage the infection, helps to determine the need for the treatment, and useful in identifying possible reinfection in previously treated patients. Okay, if you have got a VDRL or RPR titer which is more than 16, it usually indicates active disease and there is a need for treatment. Okay, but if the titer is less than 16, it does not exclude active infection, especially if the clinical signs are present. So definitely if it is more than 16, there is active infection which requires treatment. But if it is 16 or less than 16, it does not exclude the infection, especially if the lesions are present or the clinical signs are present. Okay, and negative antitreponal IgM does not exclude active infection, particularly in late disease. So even antitreponemal IgM may be negative if it is a late disease. Okay, so these are the things which you should remember. Now coming to the monitoring response to the treatment, quantitative RPR and VDRL is recommended for monitoring treatment response. Test should be performed on the day treatment started to establish the baseline titer. Subsequent titers are compared with this baseline to assess the response. This is what we have discussed. Now repeat screening recommendation after high risk exposure. The repeat screening is recommended at 6 weeks and 12 weeks. So if it is a high risk exposure case, you have to repeat the screening at 6 weeks and 12 weeks. Examples of the high risk are unprotected oral, anal, or vaginal intercourse, multiple sexual partner, then anonymous sex, commercial sex worker, and partner from high prevalence region. Okay. Patients with suspected syphilitic ulcer, if a dark field microscopy or PCR is negative, repeat testing after 2 weeks. This also they can ask that there is a ulcer. They will give the typical lesion, described lesion as which is similar to the syphilitic region where there is a strong suspicion of syphilis, but the dark field microscopy is negative or the PCR is negative, then your answer will be you will repeat the test after 2 weeks. Okay, so RPR and VDRL is important from staging point of view and monitoring treatment point of view. Baseline titer must be taken at the treatment initiation, and fourfold decline titer indicates adequate response to the therapy. Okay, individuals with ongoing high risk behavior, you will do the routine STI screening every 3 months, should include syphilis, HIV, and other STIs also, and frequency will be guided by the sexual history. So this is what is about the lab testing. Now we'll discuss about the false negative and false positive serology. Again, very, very important from the examination point of view. Okay, false negative syphilis serology. It may be because of early infection. Treponemal screening test may be negative before chancre develops. It may remain negative for up to 2 weeks after the chancre appears. Okay, so in early infection, the test may be negative. So screening test, what we do, TPPA or TPA or EIA or CLIA, the test may be negative in early infection. Second, it can be Poisson phenomena. This is more frequently asked. What is Poisson phenomena? It occurs when very high antibody titer interferes with antigen antibody lattice formation, leads to false negative VDRL RPR when tested in undiluted serum. So when you do the test in undiluted serum, the test will be negative because it prevents the antigen antibody lattice formation. It is more commonly seen in secondary syphilis, early latent syphilis, HIV infected individual management, if your suspicion is there, then repeat testing in the diluted serum. Okay, so this is because you are using the undiluted serum and there are high titer antibodies that is preventing the antigen antibody lattice formation, and that is why your test is negative. But if you have got a strong suspicion, then you will repeat the test in diluted serum. Okay, so proton phenomena is also one of the, and these are the EMQs they are asking. Okay, now coming to the late syphilis, RPR, VDRL, and IgM test may be negative in the late stage of the disease. So late stage, your test may be negative. Okay. Now false positive. What we have seen up till now was a false negative, but most commonly there can be false positive serology also. A result may be considered false positive when there are no clinical symptoms of syphilis, no previous history of syphilis, no concomitant positive anti-treponemal IgM test, and transient or persistent reactivity in a single treponemal antigen test. So you are performing multiple tests, no two tests you are confirming, but only one test is giving a positive. It may be false positive because the sample is giving negative with the other. Okay, but there is another no concomitant anti-treponemal IgM also positive. There is no previous history of syphilis. There are no clinical symptoms of syphilis. So unlike it is likely that this test is false positive. Okay, so recommended testing strategy is that screening test preferred is a EIA or CLIA, preferably test detecting both IgG and IgM, and confirmatory test. Positive screening test you will confirm with a different treponemal test. FTAB is not recommended as a routine confirmatory test. Second specimen should always be obtained for confirmation. Then assessment of disease activity. Perform quantitative RPR or VDRL when screening tests are positive. It is mainly to assess the disease activity, assist in staging infection, and provide baseline titer for treatment monitoring. This is the same thing was repeated here. Then coming to the same highlights, proton phenomena. It is a false negative VDRL RPR seen in secondary syphilis. Then dilution of serum corrects the proton effect. Then EI or CLI is preferred screening test. Positive screen confirmed with another treponemal test plus quantitative RPR or VDRL. Repeat serological testing. Repeats negative syphilitic serology. If there is a high risk exposure, repeat at 6 weeks and 12 weeks, and suspected primary syphilis if chancre is present but dark field microscopy is negative or PCR is negative, you will repeat after 2 weeks. Okay, so these are the take home messages regarding the lab testing. Okay, now coming to the treatment, that is the third part. Okay, up till now we have seen the stages of the syphilis, then we have discussed the lab diagnosis, different types of test, false positive serology, false negative serology we have discussed. Now let us talk about the treatment. Okay, this is the very frequently asked. Okay, now what is the treatment of early disease, that is primary, secondary, or early latent, that is within 2 years. Okay, the treatment is a benzathine penicillin 2.4 mega unit given intramuscularly single dose. So if the lady is in the first and second trimester and if the disease is early disease, that is primary, secondary, or early latent, then you will give single dose 2.4 mega unit. Okay, but if she is in the third trimester, you will give additional 1 dose after 1 week. So benzathine penicillin 2.4 mega unit IM weekly for 2 doses. So early syphilis single dose in the first and second trimester. Third trimester you will give 2 doses of benzathine penicillin. Remember, it is not benzyl penicillin, it is benzathine penicillin 2.4 mega unit IM dose. Okay, now if it is a late syphilis, that is latent in late latent or unknown duration, the treatment of choice in both that is first, second, or third, all 3 trimester is same, that is 2.4 mega units benzathine penicillin weekly for 3 doses. Same regimen in all trimester for late disease. Early disease first and second single dose, third trimester 2 doses. Okay, so this is the what is the treatment during the pregnancy. But they are asking the same treatment also, either early treatment or the late treatment in pregnancy, but they may give that the patient is allergic to the penicillin. Okay, what is the treatment? So that is how you remember, you have to read the guideline very carefully. So first line treatment is a benzathine penicillin, penicillin G 2.4 mega unit intramuscularly single dose. Okay, special consideration in pregnancy when treating early syphilis in the third trimester, a second dose is recommended due to low serum drug levels and risk of treatment failure. Okay. So alternative regimens. So clinical situation can be patient is penicillin sensitivity but can tolerate cephalosporins. So if she can tolerate cephalosporin, the drug of choice will be ceftriaxone 500 milligram intramuscularly for 10 days. So your regimen in this case, where the patient is sensitive to penicillin but can tolerate cephalosporin. So they'll give you specifically there is an allergic to the penicillin but not to the cephalosporin. So you will give ceftriaxone 500 milligram intramuscularly for 10 days. So your regimen from single dose will get changed to 10 days and there will be change of the drug also and the dose of the drug. Okay. Now patient is not able to tolerate IM therapy but not penicillin allergic. You will give penicillin, that is oral penicillin, amoxicillin 500 milligram plus probenicillin orally 4 times a day and you will treat for 14 days. Okay. So remember here the drug of choice is a benzathine penicillin G 2.4 mega units. The dose will be different for early disease, dose will be different for late disease. Now the situation can be patient is allergic to the penicillin but tolerating the cephalosporin, or patient is not patient is tolerating the penicillin but doesn't want intramuscular, doesn't want the injectable patient, then you give oral penicillin. Here patient is sensitive, don't give penicillin, go for ceftriaxone 500 milligram, but treat it for 10 days. Here amoxicillin for 14 days. Okay. Now coming to the timing of treatment in pregnancy, treatment of maternal syphilis more than 30 days before delivery significantly reduces the risk of congenital syphilis and parental mortality. This is what I have already mentioned. The antibiotics which are not recommended are the macrolide because they are removed from the guideline. Examples are erythromycin and azithromycin because of the increasing macrolide resistance in treponemal paradigm and poor placental transfer resulting in inadequate fetal treatment. Okay. Now, key points. Benzathine penicillin G remains the treatment of choice in pregnancy. Treatment more than 30 days before the delivery prevents congenital infection, and macrolides are no longer recommended due to resistance and poor placental transfer. Okay. Now coming to the Jarisch-Herxheimer reaction. So in the lab, we have seen Prozone phenomena. Now in the treatment, we are discussing Jarisch-Herxheimer reaction. Okay. So it is an acute inflammatory reaction occurring during the treatment of syphilis caused by rapid destruction of treponema pallidum leading to the release of cytokines. Incidence is around 45% treatments in pregnancy. Okay. Symptoms will typically occur within 24 hours of the starting of the antibiotic therapy, and clinical features will be fever, rigor, skin rash, malaise, etc. It may trigger uterine contraction also and rarely associated with the fetal distress. Okay. So almost seen in 45% patients who are treated during the pregnancy. And this is because of the rapid destruction of the treponema, which leads to the release of cytokines. Okay. Now, in which stage it is most common? It is most common this Jarisch-Herxheimer in the secondary syphilis. 90% patients will have this Jarisch-Herxheimer reaction. Okay. Primary syphilis, it is seen in 50% of cases. Secondary syphilis is seen in 90% of the cases, and latent syphilis, it is seen in 25% of the cases. Reaction is usually self-limiting. Only supportive management is required. Fluid, symptomatic treatment, antipyretics, okay, such as paracetamol. Preventive therapies which are studied but not proved, they are opioids, paracetamol, hydrocortisone, not routinely recommended because benefits are inconsistent. Okay. Key recommendations in pregnancy. Screening is recommended. All pregnant women should undergo syphilis serology at first antenatal visit. Repeat screening later in pregnancy if there are risk factors. Okay. Now coming to the management during the pregnancy. If a previously treated before pregnancy and no reinfection risk, neonatal testing is not required and retreatment is indicated if previous treatment is uncertain or serological cure is doubtful. Now this lady, she is treated previously and there is no reinfection risk, there is no specific neonatal management is required because we have already discussed if she has been adequately treated at least 30 days before the pregnancy, then the chance of congenital syphilis is very, very less. So no neonatal testing is required if there is a full history, adequate history of the treatment. Okay. Now, in which case you may have to consider retreatment if the previous treatment is uncertain or serological cure is doubtful. Okay, there you might have to consider. Now, what are the treatment consideration? Early syphilis in third trimester, give second dose of benzathine penicillin 1 week later. Okay, penicillin allergy, consider desensitization. Okay. When macrolides are used, if macrolides are used during the pregnancy, neonate must be assessed and treated at birth. Okay. So if the macrolides are used, then you go for neonatal testing. Okay. Otherwise, if she is adequately treated with penicillin, you don't require anything. Okay. Multidisciplinary management should involve obstetric team, fetal medicine specialist, and pediatric and neonatal team. Okay. Then important points which we need to remember: routine steroids to prevent Jarisch-Alexander reaction are not recommended. Maternal diagnosis and treatment should be clearly communicated to the obstetrician, general practitioner, pediatric team, and documented birth plans should be prepared with the informed consent. Okay. So Jarisch-Alexander reaction generally occurs within 24 hours of the treatment. Most commonly seen in secondary syphilis, treatment is supportive only. Prophylactic steroids are not routinely recommended, and penicillin's desensitization is preferred for penicillin allergic pregnant women. Okay. Now, this is the treatment of syphilis. Okay. Now, incubating syphilis or epidemiological treatment, we have discussed single dose 2.4 mega unit. Now, here the treatment of the syphilis, this is taken from the UK National Guidelines 2015 guideline. So, this is for non-pregnant also. It includes non-pregnant. That is why alternative drug which is given is a doxycycline 100 milligram BD for 14 days. So the first drug will be benzathine penicillin single dose. Alternative will be doxy 100 BD for 14 days. Okay. Then early or primary benzathine penicillin is the drug of choice, single dose. And alternative regimen will be procaine penicillin can be used 6 lakh units IM for 10 days, doxy BD for 14 days, ceftriaxone 500 milligram IM for 10 days, amoxicillin along with probenicillin for 14 days, azithromycin 2 gram per oral stat or azithromycin 500 milligram daily for 10 days, and erythromycin 500 milligram per oral for 14 days. Okay. But these regimens will not be preferred because these are macrolides. Okay. Resistance limits the use of macrolide antibiotics, and they should be used as a last resort only when follow-up can be assured. Okay. So if the follow-up is assured, then only, and these are the last resort. Okay. Now, late cardiovascular and gametosyphilis, again, the benzathine penicillin weekly for 3 doses. Then procaine penicillin is an alternative, but treat for 14 days. Here it was 10 days in early syphilis. In late syphilis, the same drug, but given for 2 weeks. Doxy, here the duration is 28 days. Amoxicillin plus probenicillin duration has become 20. So what we are treating, whether we are treating early syphilis or late syphilis, please remember and accordingly select the dose and the duration and the drug. Okay. Steroids should be given with all anti-treponemal antibiotics for cardiovascular and neurological syphilis. 40 to 60 milligrams of prednisolone OD for 3 days, starting 24 hours before the antibiotics. So you have to start before the antibiotics. So if you are dealing with treatment for cardiovascular and gametosyphilis, you are giving the penicillin, do not forget the steroids. 3 days of steroids. Okay, starting 24 hours prior to the antibiotics. Okay. Now neurosyphilis. Neurosyphilis, the drug of choice, procaine penicillin 1.8 to 2.4 OD for 14 days. Or if you give benzyl penicillin, not a benzathine penicillin, here it is benzyl penicillin given intravenously for 14 days. It is given 4 hourly. Okay, benzyl penicillin 10.8 to 14.4 gram. This has not been asked. Okay, there are so many regimens, but in neurosyphilis, it is procaine penicillin which is given for 14 days. You just remember, neurosyphilis is to be treated for 14 days. Neurosyphilis is to be treated for 14 days. The drug of choice will be procaine penicillin. So initially we were using 6 lakh here, 6 lakhs here. It has become 3 times. That is 1.8 mega unit to 2.4 mega unit along with probenicid for 14 days. Okay. So this is what is there. Alternative will be doxy, but you have to treat for 28 days, amox for 28 days, and ceftriaxone for 10 to 14 days. Okay. Here, if you remember, here how much was the duration for 2 weeks? Late syphilis, 28 days. Okay. Oral, if you give oral. Neurosyphilis also 28 days if you give oral. Okay. Remember these things. Pregnancy treatment we have already discussed. That is why I will not go into the details. But alternative will be procaine penicillin 6 lakh for 10 days, amoxicillin for 14 days, ceftriaxone for 10 days, and azithro, that is what we have seen. But we have to keep in mind this is the last resort. Okay, treatment of late you will have to give uh, 3 weekly for 3 doses. Okay, for late, and doxy is contraindicated. That is what you remember. Okay. And for congenital syphilis, now see the treatment for the congenital syphilis. Up till now, it has not been asked. Again, the drug of choice is a benzyl penicillin. Okay, not the benzyl penicillin. It is benzyl penicillin, 60 to 90 milligram daily IV in divided doses, given as 30 milligram per kg, 12 hourly in the first 7 days of life, and 8 hourly total for 10 days. So total treatment is for 10 days for congenital syphilis. Benzyl penicillin is the drug of choice. 60 to 90 milligram per kg is the dose. Okay, initially. Okay. Then alternative will be procaine penicillin, 50,000 international units per kg for 10 days. Okay. In children, IV therapy is preferable due to the pain associated with IM injection. Okay. Now coming to the management of syphilis in pregnancy, general considerations are serological screening for syphilis should be performed at the first antenatal visit, repeat testing later in pregnancy if the woman is at high risk of infection after the initial negative test. Adverse pregnancy outcome, although fetal infection usually occurs later in pregnancy, it has been reported as early as 8 to 9 weeks of gestation. Possible complications will include polyhydramnios, miscarriage, preterm birth, stillbirth, fetal hydrops, fluid accumulation in 2 or more fetal compartments such as ascites, pleural effusion, pericardial effusion, or skin edema. Additional findings, there will be placental edema. Okay. Now, significance of positive maternal treponemal serology. So, UK antenatal screening data shows that 1 in 650 pregnant will be positive. This is 0.15%. So, in that particular case, false positive cases are 23%. Previously adequately treated before conception are 46%, newly diagnosed are just 21%. Okay. Management of positive treponemal serology. Early referral to gum physician is recommended. MRT involvement, screening laboratory, midwifery services, obstetric team, genitourinary medicine specialist, and pediatric and neonatal team. And if the patient is HIV, you will also involve the HIV MDT also because there can be co-infection. Management when the syphilis was treated before the pregnancy. Now, if the syphilis is already treated before the pregnancy, RPR and viral test should be checked at first antenatal visit. If there is a risk of reinfection, repeat testing later in pregnancy. If there is no reinfection, no further maternal treatment is required. Neonate does not require testing for syphilis if the mother is adequately treated and if there is no chance of reinfection. Okay. Now, referral to the fetal medicine. It will be recommended after 26 weeks of gestation. Okay. Ultrasound features suggestive of fetal infection will be non-human head drops, hepatosplenomegaly. Purpose of referral will be assess fetal condition, plan antenatal management, and guide neonatal treatment after birth. Indications for maternal treatment will be indicated only if there is active syphilis at any stage, if there is uncertain history of previous treatment, and if there is a doubt about the serological cure. Okay. While treatment is not indicated, if it is a biologically false positive test or if it is already adequately treated syphilis before the pregnancy, in that particular case, treatment of the mother is not indicated. So if you get a positive serology during the pregnancy, you have to see whether she will require the treatment or whether she will not require the treatment, whether the baby will require the birth plan for the syphilis or not. Okay. Now, what are the take home message? All pregnant women should be screened at booking. Repeat screening if ongoing risk. Adequately treated prior infection, and there is no reinfection. No neonatal testing is required, and fetal medicine referral if ultrasound suggests fetal infection. Okay, so these are the points you should remember. Now, management of infants which is born to mothers with syphilis. The clinical signs of congenital syphilis will be jaundice, anemia, lymphadenopathy, hepatosplenomegaly, non-immune hydrops, pyrexia, low birth weight, failure to move extremity because of the parrot pseudoparalysis. Skin manifestations such as maculopapular rash, palms and soles may appear red, mottled, and swollen. Vesicles or bully may be there. Condylomata, that is flat wart-like plaques in moist areas such as perineum. Musculoskeletal findings like osteochondritis, periostitis, commonly affecting the elbows, knees, wrist will be there. Nasal involvement will be there. and ulceration of the nasal mucosa, rhinitis or snuffles will be there. Typically presents after the first week of life. Diagnosis usually based on combination of the clinical features and the lab testing. Okay. So neonatal syphilis serology test. Okay. So all children born to mothers with positive treponemal serology require clinical evaluation and syphilis serology test with following exception. If the mother, if it is a maternal biological false positive serology or maternal syphilis which is cured, in this case, the baby will not require any further evaluation. While rest cases, it will require a further evaluation. Okay, this is what we have discussed. Then children born to mothers treated for syphilis in this pregnancy require clinical evaluation and syphilis screening serology. Okay, syphilis serology should include non-treponemal titers and IgM at birth and at 3 months, and then 3 monthly until negative. Passively transferred maternal treponemal antibodies will be positive and unhelpful in these circumstances. Untested siblings should be screened for syphilis when maternal or congenital syphilis is made. So if there is a diagnosis of congenital syphilis, you have to test the sibling also. Okay. So treatment of maternal syphilis, we have discussed this. Okay, before 28 weeks, after 28 weeks, alternative drugs also we have discussed. So I will not go into the detail. Lead syphilis treatment also we have discussed. 3 doses, 1, 8, and 15 days. Steroid, if you are giving treatment for lead syphilis or cardiovascular syphilis, steroids, don't forget the steroids. Okay, to be started 24 hours before antibiotics. Okay, alternative will be this procaine Neurosyphilis also treatment we have discussed in the treatment part. That is why I will not go. But neurosyphilis is to be treated for 14 days with procaine penicillin. Here the drug is a procaine penicillin. Alternative will be benzyl penicillin. And in oral, the duration of treatment is 28 days. These are the highlights which you should remember. And when you are giving the ceftriaxone, it is 2 gram daily IV. Okay, duration will be 10 to 14 days and use only if no severe penicillin allergy. And diluent lignocaine can be used if you are giving IM, and if you are giving IV, use water for injection, not lignocaine. So if you are giving intravenously, you will have to use water only, not the lignocaine as a diluent. Okay, so these are the things which you should remember. So along with injection, what diluent you are using, whether you are using lignocaine or water, will depend upon the route of administration. IM, you can use lignocaine, but if you are giving IV, you cannot use lignocaine. You have to use water for injection. Steroids we have discussed. Jarisch-Herxheimer reaction also we have discussed. Okay, so this is just the summary of the same treatment. Okay, lead syphilis 3 doses. Okay, steroid should be given if you are treating cardiovascular syphilis. Prednisolone 3 days starting 24 hours before. Okay, so that finishes the topic of syphilis. Thank you.